or esophageal cancers, upper stomach cancers, adenocarcinomas. All right. So Barrett's is those changes without the cancer being in there, or you have a peptic stricture, which has to be dilated over and over again. And then 4, you have extraesophageal manifestations. You have GERD, and you still take the medication, but you still have asthma, hoarseness, cough, chest pains, and you have frequent aspiration from there. And this is from a series of articles from here, including this one here, which is small. Rakita S. Steve Rakita. He and I did residency together. We were in the same graduating class. Mike Albright. He taught me advanced laparoscopic surgery. Alex Rosemurgy. Yeah, good surgeon. That's all I'll say about Alex. Anyway. When you have Barrett's esophagus, but you don't really have GERDs, then there really is no indication. There were a bunch of studies that came out that said, hey, look, Barrett's, medical management, lap Nissens, you got Barrett's, but you don't have GERD, then this will help it resolve. They found out later on in doing multiple other studies. It does not prevent adenocarcinoma if you don't have GERD. Okay, so if you have no symptoms of GERD and you have Barrett's esophagus, you don't need to get treated. You don't do a Nissen Fundoplication or lap Nissen fundoplication. Keep an eye on it. There are many other treatments for it, but including resection if you do have cancer from it. All right. 2007. I'm going to speak from experience right here. 2007. I was a surgeon. All of a sudden, something began to change. I was doing 1 or 2 a month. All of a sudden, now I'm doing 1 a year. And then I open up a copy of General Surgery News and read this so-called discussion between a group of GI doctors and a group of surgeons. And the GI doctors were basically tearing apart the laparoscopic Nissen Fundoplication. 5 years, 80% recurrence. We know, because we scope these patients, we know that their fundoplication has come undone. It's a failed surgery. Do not do it. Medical management. I was depressed like every other surgeon. It was great. I thought it was a great surgery. Have I seen recurrences? Yes. With my own patient, yes. With other people's patients, yes. Have I done, what were called redo laparoscopic Nissen Fundoplication? Yes. There are a variety of reasons for this surgery to fail. Although, is the failure at 80%? Well, let's talk about the myths now. Now we're going to start with number 1. And this is the thing that came out. Where it came from, I don't know, but this is what came out, this is what was being discussed and published. Anti-reflux surgery is dangerous. Yes, any surgery is dangerous. But here, these are the dangers. Pneumothorax. Basically, you get a little too aggressive up there into the esophageal hiatus, and you nick the lung and you get a pneumothorax. 1 to 5%. Never happens. But it does occur. What do? Put a chest tube down. You're going to get better. Spleen injury. I mean, you injure the spleen, you got to take it out. 0.5 to 1%. Okay? I accept that. Dysphagia, secondary tissue swelling. Almost all of it resolves within 3 months. I think the longest I saw was 4 weeks. All right? Because you're going to operate on something, that tissue is going to swell, and they're going to have trouble. You put them on full liquids, as long as they're tolerating that, tell them to avoid breads and things like that. Give it time, and they'll find out it stops. Gas bloat, yep, we talked about that before, 2%. Death, 0.2%. So is it a dangerous surgery? Yes. Anybody who dies, it's a dangerous surgery. But anybody can die from surgery. You can die from anesthetic complications. You can die from infection that develops afterwards. But it's not the type of surgery that, like, quarter of your patients are dying after they get it. It's not that, doesn't have that. So let's take away myth number 1. We're going to skip number 2 for right now. And we're going to talk about number 3. 10 years, it has failed, they say. Remember the 5-year, 80%? And you will need to be repeated if that's what you want, or you go back on the medical management. All right, so let's look at the studies, the best studies right here. Here's about a 5-6 year study. They did 179 patients, and about 9% underwent revision. So 9% failed, not 80%. All right, but all right, 5 years, okay, that's not wrong. And there's the study. And between this one, which was over 10 years, 1,900 patients, 2.8% failed. And almost all those failures are within the first 2 years of the original operation. So this myth of it's going to fail in 5 years or 10 years has kind of been disproven here. So myth number 3 is now gone. Let's take that away. These are published reports, and there are many other reports that support that. Myth number 4, yes, most of these patients, it's a failed surgery because they go back on their medications. Both true and false. Here's the data. 20% resume some medication in 2 years. Yes, that's true. By 10 years, it's 30 to 40%, and this is a PPI, proton pump inhibitor. All right, I agree. However, it's not to the extent of what they were taking before. Compare that to taking a proton pump inhibitor twice a day, Zantac at nighttime, a bunch of Tums, or anything else you want to in between. It is not the same thing. You're talking about maybe one proton pump inhibitor a day. So, cost-wise, in effect, patients are obviously more comfortable. You're going to have some reflux? Of course you can. Maybe some reflux that comes back. But it's not of that type that is so severe that you're constantly taking medicine from it. Number 5, don't need it. Don't need surgery. You got medical management. That's a good point. That is a very good point. Some people don't want to take, a bunch of pills a day. Some people just really don't. But I agree, you have medical management from there. However, that is the question. Is it safe? Is it safe? And now a lot of questions that come up about that. Now I'm going to dispel some of these. Some of these that have myths within a myth right here. There's an increase in osteopathic fractures. Yes, there's literature to support that. There's a risk factor for Clostridium difficile infection. Yes, there's literature to support that. Increased risk for pneumonia. Yes and no. We're going to get into that a little bit more. Here's the big one. You take a proton pump inhibitor, it increases its clearance by increasing a certain enzyme within the liver. It's the same one that basically detoxifies Plavix. All of a sudden your Plavix you're taking, which is 75 milligrams a day, is no longer as effective and people have heart attacks and die. Terrible, isn't it? Let's see what all the other, put it all together and what it's doing. This actually comes from a paper I'm going to cite later. You can switch PPIs that can be considered in the study of side effects. If you have known osteoporosis, you can remain on your PPI. Now, I will point out, they say this is a conditional recommendation. There's a moderate level of evidence. If you have other risk factors for, a hip fracture, and you have osteoporosis, you might want to consider cutting off that PPI. Yes, PPI therapy is a risk factor for Clostridium difficile. Use it with care. Be selective about it. Look at your patient. If you're a patient in a nursing home that is rampant with C. diff, maybe you ought to think about something else to do besides the PPI. Short term may increase the risk of community-acquired pneumonia. Long term, no. So feel free. If your patient's been on it for a couple of years, don't worry about it. All right? And then when we talk about does it need to be altered? Do you need to get people off PPIs and to deal with who are on Plavix or coronary stents or risk for coronary artery disease? No. That study's been proven to be false. Bad study. So you take the worst one, you get rid of it. So not against, medical management. Is medical management safe? Yes, it is. It is true. It is true. It is safe. But there are some risks. As long as you look at the literature and say, well, this patient, would probably do much better if they were off of PPI, and we can try to treat them with something else. Let's go to myth number 2. The benefits of surgery are exaggerated. All right, now I'm going to take, basically the answer is no, it's not. Let's take this. This is published a year ago, February 19th, 2013. American Journal of Gastroenterology. Yes, thank you. Yes, not a surgical journal. Yes. Guidelines for the diagnosis and management of gastroesophageal reflux disease. Let's look at surgery. Surgical options. It is considered. Strong recommendation, high level of evidence. It is a treatment option for the long-term therapy of gastroesophageal reflux disease. Yes, strong evidence about that. Surgical therapy is generally not recommended in patients who do not respond to PPI therapy. Yes, don't go doing all that, and this is because they never responded to their omeprazole, or their protonics, or their nexium. It basically is something else is going on. You've got to figure out what it is. All right. You should figure out what's going on with a lot of these patients, except in one case. Meaning, and I'm finding this harder and harder, although I'm trying to work up with the group. You really need to monitor, to look at the lower esophageal sphincter pressure with manometry. You need to do 24-hour pH studies to see if they correlate with symptoms. I agree. I've always been a big proponent of that. However, one case you don't have to do that. Hiatal hernia, because the defect is already there. All right, it is. Surgical therapy is effective as medical therapy for carefully selected patients. Yes, strong recommendation, high-level evidence. Obese patients, do not send them for a Nissen. Get a gastric bypass. That's the recommendation right there. That's it. Don't. If you're obese, you're better off getting a gastric bypass, and that's what they say. And they give a moderate level of evidence from there. And here's the last one, which I haven't talked about.
Have you pre-authorized one of those?
No, I haven't.
Thanks.
Now, there's more than just a lap Nissen for the treatment of reflux disease. There's something called TIF, transoral incisionless fundoplication. Okay, first of all, it's not a fundoplication. Let's just take that out of the equation. They like to put it in there because now you can think about Nissen fundoplication. TIF and all its variants have never been shown to be effective. Do not, they say, do not use it. Cannot be recommended, and that's a moderate level of evidence, but they have a strong recommendation for it in this article. So we should look. I've tried to support why laparoscopic Nissen fundoplications are now re-emerging as a treatment for GERD, but let's look at some of the other treatments from there. But before we finish this one, these are the final conclusions right here. All right? So, here are the reasons. Discontinue medical therapy. Non-compliance. Side effects associated with medical therapy. Presence of a large hiatal hernia. Esophagitis refractory to medical therapy or persistent symptoms documented to be caused by refractory GERD. All right, and then go on from there. Consider your patient for surgery. Consider. If they're a good surgical candidate, you might want to give it a consideration. Let's talk about TIF, transoral incisionless fundoplication. Boy, whenever I hear that transoral or incisionless, I start to get nervous because you guys ever heard about where they would do like take appendix out or take a gallbladder out to what they call natural orifice? Notes, natural orifice transendoscopic surgery. Ever heard of it? You won't. About 10 years ago I started talking about it and was reading the data and would present and say, talk about it when you talk about laparoscopic surgery, and I would say, I just can't see it. The idea was, if you have appendicitis, let's go in through your mouth, cut a hole in your stomach, go get your appendix, cut it off, oversew it, pull it out through your mouth, with a hole in your stomach, and then sew your stomach. Boy, that seemed ridiculous. And of course it was. Most of the studies were done overseas, and the infection rate was about 40 to 60%. Woo, that's, we're talking about infection within the peritoneal cavity. The other one, let's take out your gallbladder through the uterus. Bad idea right there. Bad idea, I thought, and sure enough, it turned out to be a bad idea. So a lot of research labs around the country, including where I did residency, worked on notes, especially with animals, and you can see it's just never taken. Anytime you start cutting open somebody to another organ to get to something else, let the skin be in the way and then go from there. Let's talk about TIF. Here is the idea. It's a plication. This is the idea behind it. You go in there and you do it at 270 degrees around, and the idea is maybe to recreate that cardia right there, maybe elongate the esophagus, maybe kind of tighten up the lower esophageal sphincter. Maybe, a lot of maybes. Nothing's really been proven. I'm sure it works for some patients. I'm sure it's failed for others. Let's look back. Always good to look back and see where you came from. There have been other ones like it. Gatekeeper was the first one. Gatekeeper, you went in there endoscopically and you're right into that esophageal sphincter.